for another webinar in the very fruitful
Recording in progress.
Indian online orthopedic review course with eminent speakers from India and from Egypt. First of all, I would like to thank my dear friend, Professor Srinivas Kambhampati from India for moderating the Indian part of this course. Thank you so much, my friend, for your great effort. Tonight is a very special webinar between we have speakers and attendees from 3 continents, from Asia, from Africa, and from Europe. First of all, we would like to welcome Professor Dipen Menon, a professor of orthopedic surgery and consultants in the lower limb arthroplasty and revision surgery, Kettering General Hospital, NHS Foundation Trust from UK. Sir, it's the second time for you to be with us, and thank you so much for accepting our invitation. Second, I would like to welcome my dear friend and my brother, Professor Mahmoud Karim, professor of revision surgery, orthopedic surgery, Cairo University, and one of the eminent stars of hip arthroplasty and arthroplasty in general in Egypt. Thank you so much, sir, for accepting my invitation and for being with us in this very fruitful webinar. I would like first to thank Eva Pharma Company for sponsoring this course, and also I would like to thank the Egyptian Orthopedic Association and the Indian Orthopedic Association for sponsoring these webinars and this course. Many thanks to OrthoTV for live streaming these webinars to all over the world. First speaker will be Professor Dipen Menon, and Dr. Srinivas will be the moderator of this part of the webinar. Please, sir.
Thank you, sir. Mr. Menon, could you
just stop sharing?
Yes, please. I'll just introduce you.
Okay.
Good evening, everybody. Thank you very much, Professor El-ashhab, Egyptian Orthopedic Association, IOA, and OrthoTV. It's been a great pleasure for me to be involved in these talks. Our speaker today is Mr. Dipen Menon from UK. I'll just introduce. So, Mr. Dipen Menon is a consultant in trauma and orthopedic surgery from Kettering General Hospital NHS Trust. He did his MBBS from JIPMER and MS from All India Institute of Medical Sciences, New Delhi, and had diplomate he's a diplomate of the National Board, completed FRCS and MCH Orthopedics and FRCS Trauma and Orthopedics. He trained in trauma and ortho, completed AO fellowship in 91, fellowships in lower limb arthroplasty and revision surgery and limb reconstruction surgery. He works as a consultant in trauma and orthopedics in Kettering General Hospital since 2003. Special interests include total hip and knee replacements, revision hip and knee replacements, arthroscopic knee surgery, knee osteotomies and ACL reconstructions. He's a director of ATLS provider course at Kettering from 2022 to date, and previously clinical director, and previously honorary senior lecturer, medical education at University of Leicester. Thank you very much, Mr. Menon, for accepting the invite. Please go ahead. Thank you.
Thank you for inviting me. I will now share my screen. So I'm most grateful for this opportunity to present something on primary total hip replacement. I was told in the beginning of this meeting that there are various doctors of various levels of seniority, orthopedic surgeons attending this meeting. So I hope that I will be able to give some information right from the basic level to a slightly more advanced level. And my topic, the talk, is based on the basic principles. I will also look at the analysis of some of the registry trends, which are important in decision making. I am a consultant in trauma and orthopedics and have been so for about the past 20 years in this hospital. I'm also a lead clinician for the National Joint Registry in the Kettering General Hospital, and I have no particular conflict of interests with respect to this talk. A colleague of mine, Mr. Plakoyanis, I'm grateful to him for sharing some of his slides on registry data. So what I will be discussing today will be on adult total hip replacement. I will talk something about decision making and the importance of implant selection, and we can try and see what we can learn from some of the registry data trends. I will not be discussing on hip resurfacing, and I'm not going into great detail about the technical aspects of the operation, which most of you will know, and also you will be taught. For those who don't know, it will be taught to you during your training. So I'm just going to go firstly into some very basic broad principles which are important. And quite often it is a decision-making process which is important in hip replacement surgery. If you operate on the wrong patient, then you're more likely to get poor results. The broad principles are to operate on somebody who has intrusive pain, which is not controlled by conservative measures. This should also translate into an significant impairment in the quality of life of that individual, for them to notice a difference with the actual procedure. There can be significant stiffness and deformity, which particularly occurs in people with inflammatory arthritis, where you might have to intervene earlier before other joints are affected and due to alterations in gait pattern. Before proceeding with the procedure, accurate diagnosis and localization of pain is critical. In order to localize the pain source, sometimes one might have to use diagnostic injections into the hip joint, which is usually performed under image intensifier control with the help of an arthrogram. In addition to all of the above, the X-ray findings should suggest a significant loss of articular cartilage if you're operating on somebody with inflammatory or osteoarthritis, or femoral head destruction, for example, in avascular necrosis, ankylosis and ankylosing spondylitis, fracture, tumor, etc. So these are the important and broad principles in patient selection. In difficult patients, particularly in young adults, where the interventions that we make can have a lifelong effect on the patient, it would be helpful to follow a collegiate approach. Discussion of patients with complex hip problems, for example, congenital dislocation of the hip, and young adult patients with other problems like Perthes. It is helpful to have a collegiate approach, and this we normally do in the UK with a multidisciplinary team approach. More often nowadays, with the advent of social media, WhatsApp groups are used to discuss complex individuals. And in these instances, it is important not to give any patient-sensitive data. So if you're sending X-rays, etc., make sure that the patient's name and other details do not appear on the X-ray. Remember, one very important thing that my professor in Wrightington taught me is that total hip arthroplasty is the beginning of the patient's journey, not the end, because every joint replacement that you put in ultimately will fail. So sometimes in younger patients, they might need to undergo more than one procedure in their lifetime. And if you can reduce the number of procedures that one needs to have in their lifetime, that is always better from the point of view of the patient. The other important aspect that we need to discuss is consent. A lot of dissatisfaction and litigation arises when the consenting process is not thorough. There is useful information in the British Orthopedic Association website where we have an Ortho consent, which patients can be directed to read. And this gives the pros and cons of having a hip replacement, and also the natural history of the condition and the consequences of doing nothing. These are important because if patients have bad results, they can sometimes revert back to the legal team saying that the exact details of the operation, the consequences of not doing anything were not mentioned. It is important to manage the expectations of patients, and a cooling off period is sometimes helpful so that they can think through their options. Before we proceed with any kind of surgery, it is important to optimize the patient. We are lucky to have a high-risk anesthetic service. We refer patients, particularly ASA 3s and patients with complex medical problems, to the high-risk anesthetic service. they're able to stratify risk and explain the risks to patients in the language that they can understand. In particular, what is the risk of mortality and the development of major complications. This is becoming more important because there is a move now to operate on patients who are more ill, and perhaps some patients are in the older age group as well. And these patients can have a higher mortality. And of course, in a high-risk anesthetic service, they are able to seek opinions from other specialists and also to optimize the medical condition of the patient before proceeding with a hip replacement. Prehabilitation, we have found, is very, very helpful because patients who have reasonably good musculoskeletal strength, core stability, and proprioception perhaps do better in the postoperative period, as the rehabilitation can be made easier with adequate prehabilitation. We also have a joint school where patients are told about what to expect from surgery and the various things that they should do, like joint protection, as well as precautions. It is important that we anticipate problems and try and mitigate identified risks. For example, somebody with a neuromuscular problem may be more prone to instability, and likewise, a type B host may be more prone to infection. So one might have to alter the medications that they might be receiving before proceeding with a hip replacement. And when instability is anticipated, one might need to go for specific processes to try and reduce the risk of dislocation. I have found templating particularly useful. I tend to use 2D templating, and what I normally use is a trauma CAD system. Although nowadays, if you want more accurate templating, particularly in complex hips, 3D templating is available, which has a much more accurate method of calculating the implant size, leg length, offset, etc. And these can be done based on CT scans or EOS, which is a more recent investigation. One might have to consider compromises in a hip replacement, and if certain compromises are anticipated, then you need to determine that before the operation. I'm not going to go into great detail here, but there are various approaches to hip replacement: posterior, direct lateral, trochanteric and extended trochanteric osteotomies I use in my routine practice. Extended trochanteric osteotomies are mainly in revision scenario. I've got no experience with the anterior approach or minimally invasive approaches, but what is important to understand as a surgeon is use the approach that you're most familiar with and which you have been taught and which you have done on a regular basis. And that way you're less likely to get into complications. It is important to pay close attention to layered closure with maximum closure of dead space to reduce the risk of hematoma and infection. Now, one of the important parts of a surgeon's practice is to select implants. Now, different countries will have different ability to procure implants, but I think one of the important things to do when you start your practice is to have what I would call as a workhorse implant. This is the implant that you would use on a regular basis and which you tend to become most familiar with, and you try and use ideally 1 or 2 implants on a regular basis, and then you become very good at knowing all the sizes and all the variations in that implant and all the various techniques involved in putting that implant. This might involve going for courses and individual training. The implant that you select largely depends on your training and your surgical philosophy. And the National Registry data in the UK shows that surgeons who use many different processes have a tendency to poorer outcomes. So if you use 15 or 20 different types of processes, chances are you never become very good at using any one of them, and you might have a tendency to get poorer outcomes. And once you've selected your workhorse implant, you try and use that for your entire lifetime. Obviously, the implant will evolve with time, and sometimes you might have to go with the evolutionary process, which is directed usually by the companies. Implant selection for special situations, of course, can be different, where you might select specific implants by prior templating for conditions like congenital dislocation, etc. And when you're selecting an implant, it is important to weigh the implant costs and benefits, and these need to be taken into account. Now, when it comes to the options that are available for hip replacement, the surgeon has got flexibility in determining the fixation as well as bearing surfaces. And I will go into some detail here. The usual types of total hip arthroplasty fixation are cemented total hips and uncemented total hips. And in addition, now, more recently, there are hybrid total hip replacements, which could be a hybrid or a reverse hybrid. Now, the X-ray that you see on the left-hand side is a cemented total hip replacement where you have both the acetabular as well as the femoral components being cemented. In the right-hand side of this picture is the hybrid hip replacement where you have got an uncemented acetabular component and a cemented femoral stem. Cementing technique is very, very important if you tend to use cement. I tend to use cemented hip replacements or hybrid hip replacements. I do not use uncemented femoral components as a general rule, except for revision cases where I go for a distal fix implant. The cementing technique is important, and for doing the cement technique properly, you must understand the cementing and the chemical properties of the cement. The important thing with the chemical properties is that how long does it take to cure? Now, this can change depending on the type of cement. You've got rapidly setting cements and relatively slow setting cements. The cement that I generally use is the Palakos G cement, which has got gentamicin. And this takes roughly between 11 and 13 minutes to set, depending on the ambient temperature of the theater and humidity, etc. But that is the sort of duration it takes. But of course, there are different, more rapidly setting cements. I have used the same cement for the past 20 years. So I know the properties of the cement, and therefore I find that I'm very comfortable using it. Now, when it comes to this curing of cement, what has to be realized is that it is a heat releasing process. And during that process, the cement first expands. And just before it cures, it contracts. So because of this property, it is very important to maintain steady pressure on the component while the cement is setting. If the pressure is taken off the component while the cement is setting, then there is backflow of blood between the cement and the bone. And this results in fibrous integration, which predisposes to earlier loosening. Whereas if the cement penetrates the cancellous bone well, and this is obtained by maintaining constant pressure while the cement is setting, then you're more likely to get osseointegration between the cement and the bone. And these processes, on an X-ray, you get what is called as a whiteout, where you can't differentiate very easily where the cement ends and where the bone begins. And these X-rays with a whiteout, this processes generally lasts longer. It is important to make on the acetabular side drill holes, which is what we call as a macro interlock, and the cement which goes into the cancellous bone is what we call as a micro interlock. For this cement to penetrate the cancellous bone, it is important to thoroughly remove all the blood clot and fat by using a pulse lavage system, and also to dry the bone bed as much as possible for adequate cement penetration. Primary and secondary interlock is an interesting concept. So when you use a taper slip stem, which I will mention later, when you push the stem in, you have what is called as a primary interlock between the bone and the cement, which occurs due to pressurization, both manual, or if you want to use pressure devices, you can use them as well. And of course, the pushing in of the processes causes additional pressure. So you get a primary interlock, but with subsequent creep of the cement, which I will mention later what it means, and the continued pressure of a taper slip stem, there is what is called as a secondary interlock, where the hoop stresses push the cement into the bone, and this is associated with a slight degree of subsidence of the processes, which takes place over the first year or so with the processes that I use. And therefore, bone preparation is extremely important for adequate cement penetration. Cement pressurization, as I mentioned before, you can do it mechanically or use finger pressurization. And the use of a venting tube is advocated to reduce the risk of fat embolism. And of course, if you cement well, then you've got a higher chance of having osseointegration between the cement and bone, as opposed to fibrous integration, which could be associated sometimes with pain and earlier failure. Now, creep, I was mentioning in my previous slide, is a time-dependent stress relaxation of cement. So if you put in a taper slip stem into cement, what happens first is that the stem goes to a particular level, and then within the first year, it might subside by about 1 millimeter or 2. And during this, this is mainly due to cement creep. And this occurs after the cement has cured, because the cement has the property of creep, which is time-dependent self-stress relaxation. One of the ways cement fails is that there are tensile areas where there is high hydrostatic tension, and in these areas, there can be local yielding and microvoids, which are attached together with fibrils, which cannot be felt. And this crazing tends to absorb energy and is a reversible process. So if you look, for example, at a old China plate that you've got, you will find that there are fine cracks on the surface of the china if it's something very old. If you run your finger along this china or the ceramic, you will find that there is no roughness to it. So this is called crazing, as opposed to cracking of the china, where you will feel sort of irregularity when you put your finger on the cracked area, whereas the crazed area, you'll see what looks like a crack, but when you run your finger along that area, you will not feel any obvious irregularity. So crazing can predispose to cracking. And once a cement fractures, there is a small gap between the fractured ends, and into this end, where particles which are generated from the bearing surface can go on the surface of the processes into the cracked area and present to the bone surface on the other side of the cement. This can cause a local inflammatory reaction and granuloma formation, leading to endosteal osteolysis, which is one of the ways that bone gets destroyed around cemented processes. This can also occur in uncemented stems, but this is the way osteolysis takes place in the cemented stem. So some of the cementing philosophies rest on the type of processes. You've got what is called as a force closed system, which is usually with taper slip stems. So these stems, for example, the exeter or the C stem, they are either double or triple taper, and they are highly polished. So the processes can sink within the cement, and also when the pressure on the processes or the compressive forces are reduced, it can move up a little bit. So it is a force closed system where all the forces are contained within the cement prosthetic interface. This is opposed to a shape closed system where usually the surface of the processes has got a matte finish or is rough, and this can cause some degree of bonding between the cement and the processes. In a shape closed system, it is important that cementing technique is very, very closely adhered to, because it is less forgiving than a taper slip stem. A small crack which occurs in a shape closed system cannot be repaired by itself, and what then happens is that you have the wear particles going through the crack and presenting into the bone cement interface. So these are some of the stem types. So you have type 1, and type 1 is essentially a force closed system. Type 2, 3, and 4 are shape closed systems. And you can see some of the examples of this. These are both these processes are force closed, whereas all these are shape closed, which you can see there's roughness on the surface. And for example, this one is the luminous hip replacement, which has got very good results on the Swedish hip registry. And this one is an anatomical processes with a curve on it, and it has got right and left. So coming to types of total hip fixation, if you look at the trends in the National Registry in the UK, if you look at the last 9 years, cemented hip replacements, which is completely cemented, both acetabular as well as femoral components, the use of it has been slowly reducing. So it has started in 2014, 31% were the cemented. Now it has come down to 19. Cementless have remained much the same. It is varying between about 35 and 41%. But if you notice here, hybrid stems are slowly increasing from 27 to 43. So what I believe is that a lot of the people who are proponents of cemented hip replacement have started migrating towards a hybrid camp. So you find a proportionate reduction in the cemented hip replacements and an increase in those using hybrid hip replacements. You can see here that these are the total number of procedures which have been done in each year. And you can see that remains roughly between about 90 and about 105,000. There was a slight dip in the use during the COVID year. And if you look at the cemented stems, the most commonly used cemented stem is an exitus stem. And of course, C stem is showing a slight increase, which is a triple taper. Both these stems are force closed systems, and they're taper slip stems, which are generally less forgiving. If you get it slightly wrong also, the chances are that this processes will still last a very long time. And of course, you've got other types of cemented stems which are used much less in use, like for example, the CPT or the CPCS. I will look at some of the data from various registries now. Now, if you look at the next step, which we can look at is the femoral head size. What femoral head size would you choose? Now, the history behind this is when Charnley was using the hip simulator in the 1960s, he was trying to look at the frictional torque between the femoral head and the acetabular socket. And what was noted was he used head sizes of different, starting from 22.22, 5 to 32. And what was found was that the head with the least amount of frictional torque with the least amount of wear was the 22.225 millimeter head. So this was advocated and was quite often used in the early days. And it was very good from the point of view of wear, because the ultra high molecular weight polyethylene that we had in those days were not of as high quality as what we have now. The disadvantage with using a femoral head of 22 millimeter size is that it has got a higher dislocation rate. So this was noticed, and now that we've got better and higher quality, highly cross-linked polyethylene, the trend is to go for bigger size heads. So during the period between about 1993 and about 2009, there was an increased use in the 28 millimeter head. So this was when the polythene was also not that good. But finally, when we found that the best quality polythene has come in, which is the highly cross-linked polythene, you can find that there is now a trend to go for a 32 millimeter head. So this is a popular head. And you can see this is the data from the National Joint Registry, again, which shows that 32 millimeter head is more commonly used. And those above 36 millimeters and above are few, but 36 is also a reasonably popular size. What I tend to do for my patients is I use hybrid hip replacements in the younger patients, maybe below 70, who are physiologically below 70. And So that means even there are people who might be 75, but who are physiologically very active. In those people, I tend to use a hybrid hip. And those who are more elderly, I go for a cemented hip replacement. The heads that I use usually are 32 millimeter heads for patients who are physiologically more active. And I go for a 36 for the more elderly patients who don't have very long life left. And those people, you don't want dislocation at all. So if you use a 36 millimeter head, in fact, you want to get away with trying to only do one operation in a person who's elderly, because a second operation, they may not survive it. So if you can put a larger size head, you try and eliminate dislocation, or at least reduce the risk of dislocation as much as possible. So if you see again the data from other registries, this is the Swedish hip registry. You can see that the use of 32 millimeter heads is much more common. Same thing with the registry in Netherlands. So there is 32 millimeter heads are tending to become a more popular size. And this is probably more because of the fact that the polythene that we use now is of a much better quality and has got better wear characteristics. Again, you can see this here. 32 millimeter heads have become more commonly used. And then you have below 32 fewer and above 32 fewer, but this is the most popular size. So this is seeming to be reflected in most registries. And that is something which you're not likely to go very far wrong if you therefore follow what is being normally done in many registries, because that shows that these trends are usually followed by people, because when their own results are being scrutinized, they want to have the minimum number of revisions in their cohort. Now, if you come next to the choice of bearing surfaces, you've got metal on this. Here you can see the original metal on polyethylene, ceramic on polyethylene, metal on cross-linked polyethylene, and ceramic on cross-linked polyethylene. And then you've got metal on metal, ceramic on ceramic. Now, if you see here from 87 to 2021, the use of, originally it was more ultra-high molecular weight polyethylene with metal. And slowly from the 1990s, you have an increase in the use of ultra-high molecular weight polyethylene with ceramic. And now you've got metal on metal was being used for a period of time, but then we know that the results of this are not very good. So that has been reduced. Now the more commonly used things are highly cross-linked polyethylene with metal. You can see that that's a red bar, and highly cross-linked polyethylene with ceramic. So these two are the more commonly used things, which is highly cross-linked polyethylene with metal, highly cross-linked polyethylene with ceramic. These are the commonly used bearing surfaces. So if you look at the registry data from the National Joint Registry, which is here, you can see again that metal on poly was the purple one. Metal on metal is here. Metal on ceramic is not recommended. It's contraindicated. Ceramic on poly is rising. And you have ceramic on metal, which again is a small number. And ceramic on ceramic again is coming down, mainly due to problems with squeaking, etc. So this is also reflected in other registries. You can see the Swedish hip registry here, where again, you've got the metal, ceramic on ceramic is a small number. You've got ceramic on highly cross-linked, which is this purple bar. And then you've got metal on cross-linked polyethylene, highly cross-linked polyethylene, which is the maximum. So if you're choosing a bearing surface, what I tend to do is for a young person, I might go for a ceramic on highly cross-linked polyethylene. The reason why I don't use too much of ceramic is it's much more costly. And therefore, I select my patients quite carefully. Those who are physiologically more active, provided they don't they're not involved in any impact kind of activity, you can use ceramic on highly cross-linked polyethylene and metal on polyethylene for usually most of the other patients. So that's the way I run my practice. And you can see here, these are the survival curves for metal on polyethylene. You can see this is the failure rate of about 8% after 9 years. Ceramic on ceramic, is much less. It comes to about something like 4% in 9 years. You have the highly cross-linked polyethylene and metal, which is even better than ceramic on ceramic, and the ceramic on highly cross-linked polyethylene got slightly better figures than metal on highly cross-linked polyethylene. Same thing. Here you're looking at revision. These are all without dual mobility. And you can see the revisions here in each of these graphs. Okay. So again, we can see, 21 years following the procedure. This is from the Swedish registry. You can see ceramic on ceramic tends to perform quite well here. You've got metal on highly cross-linked polyethylene. Sorry, I better go back to that 1 minute. Let me just go back to the previous slide. So each of these are other Kaplan-Meier estimates of cumulative failure. So generally speaking, the ceramic on highly cross-linked polyethylene and metal on highly cross-linked polyethylene are good bearing surfaces. And this is all reflected in various things. We're looking at head sizes as well. That doesn't seem to make that much of a difference when you look at the years since the primary procedure. So from that, one can say that globally, it's a 32 millimeter head which is being implanted, and highly cross-linked polyethylene is the most common and successful bearing. And if you compare with ceramic as well as highly cross-linked polyethylene, ceramic and highly cross-linked has got marginally superior results, but you got to obviously look at the cost as well. Generally speaking, 36 and 32 millimeters heads have got relatively the similar survivorship. I'll come to something else now. There is a lot of move to use a dual mobility cup. So if you look at dual mobility cups, the interesting thing here is dual mobility cups are associated with slightly higher revision rates compared to a regular cup. One would have expected it to be the other way around. But I guess the cohort of patients who use a dual mobility cup are patients who are generally more problematic kind of patients. For example, somebody you're doing a proximal femoral replacement, or somebody who has got instability, you're expecting instability to occur, like a neuromuscular disease, or somebody with a significant spinal disease with alteration in pelvic obliquity. But despite this, one of the things that has been noted is that the risk of periprosthetic fractures is slightly higher with a dual mobility cup on the latest registry data from the UK. Infection risk is slightly higher, probably because you're using, there are more than 2 bearing surfaces in that. And the other thing is there is a slightly higher risk of dislocation, but that has to be tempered against the fact that this is being used in patients in whom you might expect instability. So if you look at, there are different types of dual mobility cups available on the market. You've got the hemispherical, which is more commonly marketed by many of the companies, and you've got the original one, which is spherocylindrical, as well as some with an extended superior coverage. These ones, the ones which are spherocylindrical and the ones with extended coverage, superior coverage, seem to perform better than the hemispherical dual mobility cups. Again, if you look at the estimates, you can see different cumulative survivals depending on the bearing surfaces. And you can see, if you look at some of the outlying acetabular components in the UK, Bimentum is one of them, which is a dual mobility cup. This Edinburgh cup is also a dual mobility cup. So these are outlier components, but some of them are still in use, of course. But we got to be cognizant of the fact that they can be outlier, or in other words, they're being revised more often. So if you're then looking at the place of dual mobility, there are different types of implants. So you need to select one which is perhaps spherocylindrical, or one which is got better superior coverage on the superior surface of the component. And you probably are better to limit the use of these components in somebody with, say, neuromuscular disease, epilepsy, significant lumbar spine disease, which causes pelvic obliquity, or in patients in whom you're using an endoprosthetic replacement, say a proximal femoral or a total femoral. And perhaps it is better to use the dual mobility components in patients with a low level of activity. So I will stop my presentation there, and I can take questions either now or in the end. But I think these are the sort of principles that I use for my own hip replacements. And I think each person has to select their own way they're going to be running their practice. But the principles are now all available. You've got a lot of publications. You've got a lot of registry data to go by. And based on all this, there is enough information there to make a wise choice of what you would use as an implant. So I hope that is helpful for, I have not gone much into the technical details of the hip replacement, which I'm sure most of you know to do already. But it's more to do with decision making, which I think is the area where people get into trouble. You make wrong decisions. And the important thing here also is that if you select a poor prosthesis, you might have implanted many of them, because poor results start showing after about 6 years or 7 years. And by then you might have implanted many hip replacements, and you will have a huge cohort of patients whom you would expect earlier failure. So you don't want that. So whereas if you use implants that have been tried and tested for many years, and if you implant them properly according to the proper principles and using the proper techniques, then the chances are that the hip replacements that you do will last for a long time. Thank you very much.
Thank you so much, Professor Menon, for this very interesting and very informative presentation. Dr. Srinivas, you are the moderator of this part, sir.
Yes, sir. Thank you very much, Mr. Menon. It was a wonderful talk. We know the topic is actually huge. We can't do justice for the whole area, actually. I have a couple of questions, actually, before we go on to the delegates. In your practice, which steps did you feel you improved most as you gained experience while doing total hip replacements?
Okay, I would say that cementing, if you are cementing a hip replacement, your cementing technique improves with time. And you do make some mistakes. So you need to look at your x-rays critically. Now, if you put, for example, if you're looking at what I used to do with some of my colleagues is that I used to just give a point system, where you look at the acetabular component, you look at the orientation, both in the AP and the lateral planes, the cement mantle, the thickness of the cement mantle, the whiteout, whether you've managed to get a whiteout or not. And on the femoral side, I again give points for whether the femoral component has been inserted to the correct depth, the cement mantle around it, whether it's even, whether there are any small voids in the cement, whether there is a whiteout. So based on this, you can give yourself a point system. And you have to be self-critical of your x-rays. So when you look at an x-ray, you've got to be self-critical. So you give yourself, say, out of 10, okay, that is 6, that is 7. And I have rarely given myself a 10 out of 10. Even now, I would say probably it's only about 20% of or 30% of my hip replacements where I would give it a 10 out of 10. And therefore, one of the things that you learn is the cementing technique. And as you become more experienced, you're able to cement much better. And that is one thing I've learned with time. Likewise, getting the orientation right, getting the leg length correct every time. These are all techniques which are, you can get them slightly wrong, but it should not be very badly out of. For example, you don't want to lengthen somebody more than a centimeter. Usually my hips, I'll find that it's between about 0 and about something like 6-7 millimeters. Occasionally you might find a bit more, but I've that's what you try to aim for. You also want to restore the offset. And again, that comes from good templating. So getting the hip right and getting your cementing technique right, getting your orientation right, all these improve with time. You can't, and even the best surgeons or the most experienced surgeons can occasionally get these wrong, and that happens. And it's a matter of self-reflection and learning.
And what are the most important parameters that one should look at while going through the NJR, National Joint Registry data?
So first thing is you would want to know what implant you want to select. So for that, you would be best looking at survival curves. So if you want to select an implant, you're better off selecting an implant which has been there in the market for a long time. There's no point selecting something which has just been there for a year, because unless you are in a research unit and you want to sort of study the long-term results, in which case it is best to do a small number of patients, maybe about 50 or 100 patients, and then you follow these patients up long-term and then try and look at your results. So if you're using a regular practitioner, you're best using an implant which has been there for a long time, which has been tried and tested, and which has proven track record. So if you use those kind of processes, you're unlikely to get it wrong. That is one thing you want to check. You want to then check what are the bearing surfaces. As I said, you want to check about what are the kind of the head sizes, etc. You might look at those things. You might look at patient characteristics, and then there are a lot of hypotheses which come out of joint registry data. And sometimes that is helpful for research, because most of these joint registry data cannot be taken as a be all and end all. You can, what happens with joint registry data is that it gives you a trend, and then that has to be tested. What is the reasons for that trend to occur? And quite often, a particular trend might be reflected in many registries, many different registries, and that gives you an idea. Gives you research ideas. So that is helpful for younger people who are interested in research ideas. You can look at registry data, and that can give you a hypothesis for further research. Other things that you might look at with the joint registries, you look at different processes, and they're all enumerated there, and you've got the long-term results of each of these processes and the total number that are implanted. And usually these numbers go into they're very high numbers, and they also reflect very general data. The joint registry data is not from a single surgeon. It's from thousands of surgeons. So what you then have is how a process behaves when it's used by a general group of surgeons, as opposed to just what is being used in one or two big centers where they have got a few experienced surgeons using it. So their results may not translate the same way into other centers. So for example, if you use an Oxford medial unicompartmental knee replacement, of course, this is not from hip replacement, but I'm just digressing a bit. You will find that the data from Oxford will be better because they are the actual designer surgeons. They have got, much more experience in using the Oxford unicompartmental knee replacement. That same result may not be translated everywhere. So this one will give you a sort of idea of how a process behaves in a large cohort of surgeons, and that is more generalizable compared to data from a randomized controlled trial, for example, where you're trying a new processes. So I think those are the sort of things you try and look at, and you have tremendous amount of data. So I cannot go into each bit, but and you can pick up what interests you, because that data will be available. You can pick up, if you've got a particular interest, you want to look at a particular thing, you will find it. The infection rate following hip replacement, how many cases. So if you look at revision, for example, you will find that most hip replacements, in the first couple of years, there will be a peak in revision rate. And the reason for this is there will be some of these patients get infection, and some of them have instability. These are the two most common causes of early revision. And you will then find that you have a steady state. So you'll have a peak initially, followed by a steady state in the graph where there's not much failure. And that will go on till about 10 years. something like that, if the process is good. And then slowly after that, you'll start finding an increase in the revision rate. That occurs mainly from wear, loosening, those kind of things. So they're the completely different set of factors which cause the late revisions. And therefore, if you're following up patients in the long term, you might want to see patients early on, maybe quite early on, if you're doing long-term results, maybe in the first few weeks, maybe in the first year, second year. If the processes performs well in that period of time, then you don't need to follow these patients up. I'm talking about research people. And they can, for about 10 years, maybe you might have to follow them up after 7 years, 10 years, and then after that more frequently, because then you have other complications occurring. So if you're introducing a new processes into the market, usually they will not allow it in the UK unless it passes through a committee. And they will look at what the early results are. And ideally, you do it on a cohort of patients. You should have at least 5-year results before you introduce it into the general market. And even then, sometimes we can get it wrong. So just running after new technology is not a very good idea. You're better off sticking with things that have been tried and tested. That is one message I can pass to everybody, and stick with one process if you can. Don't keep on using one process one day, another one another day, third one, third day. Your results will not be good.
We have one question from one of the attendees. It's Dr. Gamal Qasim. He asks, is that the same precautions for both cemented and non-cemented techniques? And which technique is preferred regarding weight, age, bone quality, and save mobility?
So I would say weight, it is always helpful. In the UK, we are having a little bit of a problem now with patients with a high BMI. Now, I don't know how common this is in other countries, but we have patients now with a very high BMI. And if you operate on patients with a BMI more than 40, then you will find that the results generally tend to deteriorate. And there are various reasons for this. There could be early loosening, slightly higher risk of infection, mainly because of hematomas, and because you're using anticoagulation, and in patients who've got a high body fat, you might have an increased risk of infection. And sometimes these patients do have sleep apnea, those kind of things. So they might get chest infections, and those can spread to the hip. So the failure rate in patients with a high BMI more than 40 is higher. So if you remain less than 40, again, it reduces. But ideally, if you can get patients, with a BMI less than 30, then you're less likely to get complications. Activity. Now, if you're selecting a processes like an uncemented processes, you're better off using it in a younger patient with good quality bone. So usually a person who's very active, you will have good quality bone. And in those kind of situations, you can use an uncemented processes. In patients who are less active, osteoporotic bone, if you use an uncemented process, you try and hammer in a stem, you can sometimes break the femur. Acetabular fractures are less common, but it can also happen, particularly if the bone quality is poor. And therefore, you should be very careful if you're using this. And you might not, as you know, as the person gets older, the cortical medullary ratio increases, you see. So you'll have an increased medullary canal size, and the cortex thins from osteoporosis. So in these patients, if you ream, you will not feel much of you don't get that sort of feeling of how when you're reaming, you get a sort of resistance. That resistance is much less. So you can over ream, and you can also break the bone. So I would advocate against the use of particularly uncemented femoral stems in patients who have got poor quality bone. So young patients with good quality bone, you're better off. You could use uncemented on both sides and get good results.
Thank you very much. If there are no other questions, we will move on to the next speaker, Professor El-ashhab.
Yes, sir. Thank you so much, Dr. Srinivas. Many thanks to Professor Dipen Menon for this very interesting and very illustrative presentation. Now we will move to the other part of the webinar. The next speaker will be Professor Mahmoud Abdel Karim, Professor Trauma and Orthopedics, Cairo University. He had a diploma of medical education from UK, and he's an AOTrauma Egypt educational officer. He is a ICJR Egypt board member, and one of the stars of hip arthroplasty in Egypt. Professor Mahmoud, please, sir.
Thank you very much, Professor El-ashhab, for inviting me for such a great meeting. And I just wanted to say that I'm quite delighted to actively participate in this great meeting with our dear friends from India, Professor Menon and Professor Kambhampati. Today, I'd like to discuss with you about an update regarding the diagnosis of periprosthetic joint infection. And I'll try to present this update through applying different techniques, different tools in diagnosis on a case-based discussion basis. I based this presentation on the following references and resources, including the Pro-Implant Foundation, European Bone and Joint Infection Society, and mainly on the second International Consensus Meeting on Musculoskeletal Infection. I was delighted to be part of the delegates and in collaboration and in conjunction with other colleagues from different countries all over the world, including those dear friends from Egypt. And definitely, I was delighted to work closely with Javad Parvizi in this consensus. So we are going today to discuss a bit about definition of PGI, algorithmic approach and patient assessment, scoring system, including the ICM-30, which I just mentioned, new tests and biomarkers, and finally, just touch briefly about the European Bone and Joint Infection Society definition. And these are going to be my learning outcomes for today's talk. Right, let me start by this case. 27 years old female patient who had this total hip arthroplasty 2 years ago. I wasn't quite sure why she had that, but apparently she told me that she might have a sort of a vascular necrosis following the epidemic of COVID. And then she sought medical advice, and then after core decompression, she had to do that. And I don't know the reason why she was operated upon having like cemented arthroplasty on both sides. So clinically, she presented to me with ongoing pain for several months, no fever. Wound was well healed with no obvious signs of infection. I mean, on the wound level, no sinus tract, and she was complaining of shortening on that side. So let's start with this question coming from the consensus. What clinical findings, fever, erythema, reduced range of motion, are the most sensitive and specific for diagnosis of PGI? So what I'm going to do, I'm going to apply some question and answer it from different parts of the consensus, different evidence-based literature, and other things. So a painful prosthetic joint is the most sensitive but least specific clinical finding in PGI. Signs of deep tissue involvement includes obviously sinus tract purulence, abscess, and extensive necrosis, and these are considered to be the most specific signs. According to EBGIS, pain and reduced range of movement are the most sensitive, but the sinus tract, again communicating with the joint or exposed prosthesis, are the only fully specific clinical findings. It's very important to take careful, detailed history about the problems and with wound healing, prolonged wound discharge, dehiscence, superficial infection, and then we should suggest that infection is likely. And there is an inverse correlation between the prosthesis age and positive microbiological findings. And whenever we encounter early loosening, we need to think of the possibility of the hidden PGI than late loosening. So there are quite a few indirect measures of infection, all suffer from lack of specificity, and making the diagnosis of PGI remains an imperfect and challenging. So which test or imaging? Well, through this case-based lecture, I'm going to cover different tools, including history and physical examination, and different tools, including laboratory markers and new biomarkers. So available tests for PGI includes some in the serum, some in the synovium, imaging techniques, as well as on tissue samples. Throughout this lecture, I'm going to elaborate on different items. The most important algorithmic approach would include cost-effective systematic approach to a patient complaining of pain after total joint arthroplasty. And this would avoid lengthy and costly workup. What is the definition of periprosthetic joint infection? And can the same criteria be used for both joints? Well, according to the consensus, we might have some confirmatory signs, including two positive growth of the same organism using standard culture methods, or a sinus tract with evidence of communication to the joint. And then they further added some minor criteria, which I'm going to elaborate on one by one. And they used to give a score to each minor criteria. And the cumulative score, if it's more than 6 or equals to 6, this means that it's infected. If it's inconclusive, whenever they get a cumulative score 3 to 5, and less than 3 might not be infected. And if preoperatively we can't determine, or it's still inconclusive, we might resort to some intraoperative tools, including positive histology, purulence, and single positive culture, as we are going to elaborate. A very important thing for all our junior trainees and to every single surgeon, whispering in your ears that clinical judgment should still prevail and guide the physicians in the management of patients. Why that? Because there isn't, up till now, a 100% conclusive test or confirmatory for infection. So every patient with a painful total joint arthroplasty or a planned revision should be considered infected until proven otherwise. History and physical examination are quite critical in the initial evaluation. You need to take proper history about wound problems, antibiotic treatment, prior history of infection, and the character of pain. So again, back to the case. When I encountered this case, I thought, oh God, this might be infected from the different radiological signs, etc. So what sort of labs I would order for that? Well, every patient's initial workup should include a serum, ESR, and CRP. According to the consensus, the thresholds for ESR of 30 millimeter per hour would be given 1 point in the score and correlated with chronic infection. There is no role, according to the consensus, in the acute infection. And even the ESR is not included in the EBJS, European Bone and Joint Infection Society scoring or algorithm of infection. The CRP, we have to be very careful. We need to know whether the lab is saying like more than 10 milligram per liter or 1 milligram per deciliter. So you need to review your lab according to the which units they are using. It should be quantitative, and we need to watch the units as I just mentioned. So again, in the acute PGI, if it's more than 100, it would get 2 points, and the chronic more than 10 gets 2 points. So a very important question when we encounter such cases, that the presence of normal or below high levels of ESR and CRP, would this rule out the diagnosis of PGI? Well, the answer is definitely not. So whenever you encounter ESR and CRP, which might be normal, this does not necessarily exclude the diagnosis of PGI. Why that? Because they might still be normal in slowly growing organism, kind of PGI. And also whenever in some patients who are administering antibiotics. They are falsely elevated also in systemic inflammatory states and some other extra-articular infection. They might be false negative in low virulence organisms as, for example, C. acnes. They might be even physiologically elevated in the early postoperative period following index arthroplasty. So they might be difficult to be interpreted correctly in the acute setting. In light of these shortcomings, there is clear need for alternative serological markers and not only depend on rather just normal ESR and CRP to rule out infection. According to EBJS, CRP is especially engaging the systemic severity because we all know that ESR remains high for longer time. However, CRP cannot be used alone again to confirm or exclude PGI. A raised CRP without other cause should prompt the clinician to think about the likelihood of PGI. So back to our case. So what I found that the ESR, first hour 40, second hour 70, definitely elevated. CRP is 18, and the patient was anemic. So would this patient to be candidate for aspiration? Well, who should be aspirated? Whenever you encounter any patient with elevated ESR CRP, the most important thing is high clinical index of suspicion. And also they usually say selective THAs, and some surgeons might just do aspiration for every single total knee. If we have the synovial aspirate, what are we going to send for? Some juniors might just think that the aspirate should be analyzed for synovial culture and sensitivity, which is not the correct course of action. We need to ask for white blood cell count and polymorphonuclear leukocytes percentage, in addition to synovial culture and sensitivity, and not just 2 days or 3 days culture and sensitivity. It should be extended, as I'm going to elaborate upon that. In addition, feel free to use leukocyte esterase strips, alpha defensin, if you have it, synovial CRP, next gene sequencing, in addition to crystals. Let's dig into a very important question asked by quite a few juniors. In the setting of dry tap, should you lavage with a fluid? According to the consensus, they recommend against that because actually you might manage to introduce some infection. Again, it's controversial, but in my humble experience, I would stick to the consensus recommendation. What about the synovial white blood cells? We usually ask for total and differential. And the elevated synovial white blood cells in the acute setting, it would be up to 10,000, and the chronic at 3,000. And whenever we reach this threshold, they take usually 3 points. That's or leukocyte esterase. Again, one of them, whenever they are positive, or getting the threshold, now the patient might take 3 points on the score of the consensus. What about synovial polymorphonuclear leukocytes percentage? Acute stage, 90%, chronic 70%, some others might say 80%, but according to the consensus, it's 70%. And now they might take 2 points. How does the level of leukocyte count and neutrophil percentage in synovial flow change with time? Well, as time goes, the leukocyte count and neutrophil percentage would drop as one moves further away from the index arthroplasty. And that's why, and that's the rationale basically behind using different thresholds for acute and chronic. I came across this new term, in the last few years, which is called absolute neutrophils count. And why this count now being considered, although it's being also controversial. So one of the studies, or some studies, showed that what's meant by synovial absolute neutrophil count is basically by multiplying the white blood cell total count times the neutrophil percentage. In chronic patients with discordance, so if you encounter some patient where they have increased total leukocytic count with decreased polymorphonuclear leukocytic count, or the contrary to that, decreased white blood cells with increased neutrophil counts, then you could calculate the absolute neutrophil count. And according to some authors, they say if this calculation results in around 4,000 cells per microliter, then this patient might be infected. If it's less than 1,000, there might not be infected. But again, it might be useful in some studies as a useful tool, and some others said it might not be. It might be a bit controversial. Again, I would definitely ask for culture and sensitivity for the synovial fluid. The sensitivity isn't very good. It's 52%. The specificity is very good, 95%. What does it mean for the juniors? This means that this is quite specific. So if it's positive, this means that it's highly likely to be infected, but not sensitive, meaning that if it's negative, this does not necessarily rule out infection. So it cannot be used just as a screening test to rule out PGI. And again, it's of high incidence, so you might encounter that in up to 20 to 40% of our patients where we might culture negative infections. How we improve the culture yield? The patient should be off all antibiotics for a minimum of 2 weeks. We need to hold the culture for 14 to 21 days, and we need to avoid swabs by all means. And again, we do our best to use blood culture vials, and I'm going to elaborate on this later on again. Other tests like gram stain, systemic white blood cells counts. Well, no evidence to support use of gram stains as previously, or even the systemic white blood cells in the diagnosis of infection. Other tests, CT or MRI, again, no conclusive evidence to support the use of either in the diagnosis of PGI. However, it might evolve as time passes. What about nuclear scan? Because it's quite expensive. In such patients, should I have ordered nuclear scan? Well, the role of diagnosis is emerging. However, we need to appreciate that false positive results around loose aseptic implants and even in the postoperative period. So some authors might say that it might not be reliable within the first 2 years after total hip because it might be falsely positive, and even up to 5 years after total knee arthroplasty. That's according to the EBJS. A negative isotope scan, however, might have high negative predictive value, makes infection unlikely. Diagnosis isn't established by other means, not scheduled for reoperation, then I might opt to ask for nuclear imaging. However, it wouldn't be my first choice. If I'm going to use that, I might combine it with indium scan, sulfur colloid gallium, which improves the sensitivity and the specificity. What about FDG PET scan? Currently, there is no standardized interpretation criteria exists for it in the diagnosis of PGI, but might be evolving. So for such an expensive test, I wouldn't be necessarily rushing to use nuclear imaging scan unless I'm going to take into consideration all the variables which I just mentioned. What about D-dimer? It's fibrin degradation product, a screening test in pulmonary embolism suspicion. If the ESR, as we all know, did not normalize until 6 weeks postoperatively, and also the CRP might remain elevated for 2 weeks, in comparison, the serum D-dimer advantage that its levels might be normalized by postoperative day 2. So thus the advantage is both superior sensitivity and specificity compared to ESR and CRP, and also a rapid decline to baseline levels. I came across this paper in 2017, which showed that it's a promising marker for the diagnosis of PGI, and even it outperformed ESR and CRP with quite great sensitivity and specificity. But in my hands and my humble experience, I usually use it just to determine the optimal time of reimplantation. Again, there is no optimal time or a tool to define optimal time, but I usually include it in addition to my clinical index of judgment, but also I include the serum D-dimer in this context. What is the threshold for in the acute? There is no threshold. In the chronic, it's 860, and then you could get 2. But again, you have to appreciate you can't get the same 2 points for serum CRP in addition to D-dimer. So always take into consideration if you have either would take 2, not 2 plus 2 equal 4. What is the diagnostic accuracy? I just mentioned 860 or 850. And again, further studies are needed in order to validate the threshold or establish a more rigorous threshold. Plasma fibrinogen, another marker, which showed in one of the other studies that it exhibits better performance than plasma D-dimer in the diagnosis of periprosthetic joint infection. Should we routinely assess serum or blood metal ion levels like cobalt, chrome, when working up a patient with painful TGI? Well, there is no data to suggest that, and thankfully, or worldwide, especially, for example, in Egypt, we no longer have a metal on metal. However, there is enough evidence that whenever you encounter encounter one of those patients who have painful metal on metal, you would definitely want to ask for these levels. In addition, if you have the suspicion in some patients, like the modular, with those with some modular neck femoral components, and in certain metal on poly total hip, in which trunnion corrosion or trunnionosis or taperosis is suspected, then you might ask for these levels. What about leukocyte estrays? Right. Any role in the diagnosis? What does it correlate with? And what would you do if the sample mixed with blood? So to start with, this is an enzyme secreted by activated neutrophils, which have migrated to the site of infection. It used to be called the pregnancy test of PGI, and then later on the same name might apply for the alpha defensin. It's a point of service care or test with real-time results, with quite good sensitivity and specificity, and positive as well as negative predictive values. So it correlates actually with the white blood cells of more than 3,000 per microliter. I would always try to keep it in my OR if I'm suspicious, and I would take few drops from my patients. If the sample mixed with blood, we can add to this concentration through centrifugation at 5,000 RPM for 2 to 3 minutes, and then the supernatant fluid applied to the LE strip. Again, what is the threshold? Or here we usually say if it might be negative or trace 1+ and 2+. Whenever the patient having 2+ in the acute or chronic infection, this gets the patient gets 3 points for PGI. And that's how it looks. It's quite cheap. We usually have it in the bottle. It's like, as I said, the pregnancy test. And these strips and these bottles are quite cheap. And you usually have this different colors for measuring the ketone bodies in urine and pH and sugar, etc., including the leukocytes, as you could see here. And then a few drops from the synovium. And then if you could get this dark pink color or violet or whatever you call it, and it's 2+, it gets the points, the being positive for the PGI according to the consensus. What about alpha defensin test? Right? Again, if it's positive, it gets 3 points, exactly as leukocyte estrays, and you have to appreciate that either of them. So you can't say 3 and then 3 for this or that. So it's antimicrobial peptide released again by the neutrophils in response to the pathogens. Some studies showed that very promising results, up to more than 95%. It provides consistent results regardless of the organism type, gram type, species, or virulence. And again, the beauty about that, it usually said that even if the patient on current antibiotic administration, or even if he's having systemic inflammatory arthropathy, it might be a very good tool. And again, the same sort of thing is the same procedure. You take a few milliliters from the synovium and apply to the test and then get the results. Let's discuss about the precaution, different types. Is it always valid? What about false positive and comparison to LER? Well, it is critical that the aspirate is actually synovial fluid, not pure blood. However, they usually say that simple blood contamination does not appear to affect the test. Aspirate from saline lavage are not appropriate, so I wouldn't try to inject some saline and get the aspirate back and then apply the test. Biomarkers assays should not be utilized in the first 4 to 6 weeks after surgery. So it's not very handy in this period. Aspirates from prosthetic joints with metallosis might reveal 30% false positive alpha defensin rate. False negative results might be encountered and observed in the setting of sinus tract. So I wouldn't recommend that. Has not been validated for use in the setting of a spacer block. But again, sometimes I add this to my clinical index of judgment, or my clinical judgment. There are 2 types, laboratory-based one, like the ELISA test, which demonstrated the highest ever reported accuracy. And there is also the lateral flow test, which we used to have in Egypt. And again, they say it's highly specific and rapid tests. Okay, I came across one of the studies which showed that still the alpha defensin is in 100% specific to PGI, and sometimes it gets false positive results. That's why in the studies, they started to add to this the synovial CRP threshold of more than 3 milligram per liter. And actually, in this study showed that the synovial CRP reversed all the false positive results. What about the comparison between the very expensive alpha defensin, if you have it, compared to LER or leukocyte esterase? Well, I came across this updated meta-analysis, which comfortably show that the both are valuable synovial fluid markers for PGI with comparable high diagnostic accuracy. So nowadays, if ever, I would only apply the leukocyte esterase rather than the very expensive alpha defensin. You have to remember that the alpha defensin not valid in cases of adverse local tissue reaction, hematomas, acute inflammatory arthritis, or gout. So back to the case, how would I manage this case? Well, I thought that it might be infected, so I took her to theater. Oh, I forgot to mention that the culture were negative from the synovial aspirate. But again, whenever I was doing this revision, there is also, where you do even a single or a revision for aseptic loosening, there is a very important question you should ask yourself. Should intraoperative culture should be taken during every revision, let it be infection or not? And if so, how many? Yes, routine culture should be taken during every revision, not only for infection. At least 3 intraoperative cultures, ideally 5, and according to other criteria from Oxford, might be 6. A very important tool I came across, I don't have massive experience, but one of the professors mentioned this to me about methylene blue. Dilute methylene blue of 0.1% was instilled in one of the studies before debridement. And this residual dye was removed and staining the tissues behind. And this study, whenever they debrided destained tissues compared to the non-stained tissues, the result showed that more bacteria were found in the methylene blue stain versus unstained tissue, suggesting that there is a role of methylene blue in providing visual index for the proper debridement. I thought just to add this info for our junior trainees. What is the instance of culture negative infection, as I just mentioned? Well, actually, it might be reported up to from 5 up to 42% in some series. We are going to elaborate more on culture negative PGI because we encounter them quite often, like in this case. There is currently no gold standard for diagnosing culture negative PGI. We need first to differentiate whether this is really culture negative or truly negative, i.e. aseptic loosening, or falsely negative results, in which case the diagnostic test might have failed to identify an organism, but there is actually truly PGI. So there are 2 broad categories or groups of patients which might have culture negative PGI. Group A, in which these patients are clearly infective, but microbiological cultures remain negative. For example, whenever the patient is administering antibiotics, or the other reason might be that we are failing to culture the organism, especially that most bacteria responsible for PGI form biofilms and simply do not produce colonies when they are transferred to the surfaces of agar plates. Group B, a potential PGI, but the cultures are negative with no obvious clinical evidence of infection as a sinus or purulent discharge. This might represent a rather low-grade infection caused by fungi, mycobacterium, or some other atypical pathogens like Coxiella, Pernetti, or Propionibacterium. Some, if not most, of the cases of so-called aseptic loosening might represent low-grade PGIs. I came across some authorities, and they usually say, well, there is no such thing as completely aseptic loosening. But again, this might be extreme view. Again, in addition, you have to appreciate that there is also what's called viable but non-culturable bacteria, and which you could only be able to yield this bacteria with bacteriophage. Usually, the microbiology of culture negative includes fungal and mycobacterial infections in over 85% of cases. So you have to be very aware of that, and to order and request your culture to be extended, and also to ask specifically to cover fungal and mycobacterial infections. The remainder are bacteria, including what's called fastidious bacteria, which are difficult to culture and require specialized microbiological techniques, including Procella, Coxella, Pernetti. You don't need to keep these names, guys, by the way. I'm just speaking to our junior trainees. You just need to involve your microbiologists and infectious disease specialists whenever you suspect any of those. So how to decrease the so-called culture negative infection or results and improve your culture yield. So every single effort should be made to isolate the infecting organism prior to surgical intervention, like no swabs, no sinus tract culture whatsoever. The patient should be off antibiotics for at least 2 to 3 weeks, but antibiotic prophylaxis need not to be withheld. Previously, we used to withhold the antibiotic before taking the cultures. 14 to 21 days unless enrichment technique as sonication and or blood cultures bottles incubation, direct and expeditious transportation to the lab. The last thing we need to do is to take our samples and then wait for the nurse, and then it stay there overnight, and then they might send it in the morning. That's not accepted. That the biopsy or the specimen should be immediately transported to the lab, and they should be processed upon receipt. We need to take multiple samples, as I just mentioned, 3, at least 3, ideally 5 or even 6. Single biopsy can be obviously false positive. We need to use separate instruments, and we need to take different samples from different parts or different interfaces, including the bone implant interface membrane. I like this table. Feel free to just to print it, put it on your ward or in your OR, and it includes from Javad Parvizi JBJS article in 2014, strategies to minimize the rate of culture negative periprosthetic joint infection. And I discussed about quite a few of these strategies. Again, they always recommend to use what's called the blood culture media or the blood culture bottle, and they usually decrease the time to detection during analytical phase with full spectrum of blood culture media solutions. So as I just mentioned, we usually ask for extended culture for 14 to 21 days. Whenever you use these, they might say, well, this time might be reduced up to 9 days or even less. The BD Bactec, they call it Bactec, bottle portfolio provides a full line of blood culture media developed specifically for detection of different microorganisms or bacteria, including aerobes, anaerobes, yeast, fungi, and even mycobacteria. It improves the time to detect and organism recovery from both adults as well as pediatric patients. There is a very nice article in 2020 in JBJS American about pediatric osteoarticular infections using blood culture bottles for the diagnosing these kind of infection. And using the blood culture bottle compared to traditional culture systems, they should to improve the microbiological identification rate, reduce the time, as I just mentioned, and permitted even a smaller volume specimen. Are there significant differences in the yield of culture between preoperative aspiration and intraoperative culture? So, for example, if you have aspirated this patient, would you again take intraoperative culture? Definitely yes, because there might be difference. And this is especially valid in polymicrobial infection or low virulence organism. So again, I would insist on taking multiple intraoperative tissue samples, even if the aspirate revealed the some sort of organism before the operation, because you might encounter another extra organism which constitutes what's called polymicrobial infection. You might need to combine more than one antibiotic. Okay, this is very important thing to take into consideration. Do we need to take bone cultures, and would these provide additional diagnostic accuracy? Well, this is inconclusive. They cannot recommend, according to the consensus, for or against bone biopsy to provide additional diagnostic accuracy. But again, you need to do a thorough and very, very aggressive debridement. And if I find part of the bone is very suspicious and I'm going to debride it, I would definitely include it in my culture specimen. What about sonication? This is the use of low-intensity ultrasound for disintegration of biofilm. Basically, it takes the loose microorganisms from the surface of the implant or explanted implant. And then subsequently, we culture the sonication fluid and prove to be more sensitive with increasing the yield rate of bacteria compared to conventional periprosthetic tissue cultures. So the process includes that when we get the implant explanted, we put it in a container, rather a hard jar rather than just a bag. And then we add to this ringer solution, which is red in color here, and then expose it to vortex for 30 seconds, and then sonicate it in a bath, sonication bath, and then vortex again, and then concentrate that by using centrifugation for 5 minutes, and then we get the aspirate, and then we culture this or apply this to the plate, to the culture plate. As you could see here, I love this slide from our dear friend Andre Trampus. As you could see here, these are the number of bacteria, the yield rate on the sonication on the plate, which was delivered or yielded by sonication compared to the traditional culture, periprosthetic culture tissue. Can you see how much different yield rate? So this definitely increases the yield rate of culture organism in chronic infections. So according to the consensus, if there is a role for sonication, yes, definitely. It's a viable method, especially for detecting pathogens, particularly in the setting of culture negative infections. You will come also across some other tools like what's called dithiotretol, which is strong reducent agent and protein denaturant. It's used to dissolving biofilm, so again, it might improve the bacterial yield. There is also the PCR polymerase chain reaction, which is superior to culture in the detection of low virulence bacteria. So again, I would resort to these tools because they are expensive only whenever I encounter culture negative or atypical organism. Multiplex PCR can also deliver results within few hours in an automated analysis versus several days for the standard culture. And again, another benefit that it retains high sensitivity and specificity for patients on antibiotics. However, it's quite expensive and again, susceptible to contamination. What about the emerging molecular diagnostics and next gene sequencing? Like traditional culturing techniques and of samples, the NGS, next generation sequencing, is able to extract the microbial DNA and obviously allows for faster and more accurate diagnostics, especially whenever you encounter culture negative infections. I came across this study in 2018, which showed that the traditional culture were positive in about 61% only of patients. In comparison, the NGS was positive in 89%. But there is here a caveat, because the NGS might be still positive in some aseptic revision up to 25%, and it might be even positive in some primary cases up to 35%. So we need to be cautious at the identification of pathogens in aseptic revision on primaries is a source of concern and needs further research. It still remains unclear whether the relative expense of these newer tests can be justified, especially in current economically challenging situation in different countries. At surgeries, we might resort also, if it's still inconclusive, whether we have PGR or not, or as an additional test, to have what's called frozen section. It's a useful test in these cases. We include 3 deep samples. Again, the threshold is 5 to 10 white blood cells per high power field. Histology have lower sensitivity than specificity, especially with microorganisms like coag negative or C. acnes. And again, if you have positive histology, this takes 3 points according to the consensus. Well, another benefit is the presence of visible microorganisms with appropriate histological stains like Gram stains, Zell-Nielsen stain, fungal stains, have low sensitivity but quite specific, especially for identification of these atypical organisms like fungi, filamentous bacteria, or mycobacteria. According to the consensus, what is the diagnostic accuracy of histology tests and thresholds? Again, there is wide variability, and that's why we say from 5 to 10. But the most important thing before embarking on such tests that you need to know and appreciate that it's highly operator dependent. So if your pathologist isn't well versed in this technique, you might have different and controversial results, and it's not very reliable. Again, in this case, taking her to theater, I've done for her again leukocyte strays and collected the samples as I just mentioned. Unfortunately, I got the samples as Acromiobacter denitrificans, which is quite a typical organism. But the major concern that it was actually Candida auris. And this explains why the aspirate was revealed to me in the first place before taking the patient to theater and to do this first stage as being negative. She developed what's called Candida auris in addition to this atypical organism. I always involve one of my dearest colleagues who is infectious disease specialist in my university, and sending him these results, he said, well, this is one of the worst Candida in the world. So let's discuss again, what is the optimal method to diagnose fungal periprosthetic joint infection and not to miss, as happened with me whenever I was aspirating. We need to expose that to specialized culture media, which even might take up to 4 to 6 weeks and even might still be negative, at which point you might need to resort to other molecular techniques, which we just mentioned. By the way, there is a difference in the type of pathogen that can cause surgical site infection between hip and knee arthroplasty. According to the consensus, there is limited evidence. However, isolated studies have reports increased prevalence of streptococcal culture-negative PGI around the knee. In comparison, and around the hip, you might encounter staphylococci, enterococcal, or pseudomonal PGIs. That's, again, just to remind you about what I've done. So I done a static spacer because of this pelvic protrusion, and I added to that antibiotics. And there is a very common question: should antibiotics be placed in the cement spacer be tailored to the sensitivity of the infective organism? Well, in this case, I didn't have organism. So I merely added vancomycin, as we usually do. However, according to the consensus, we need to know and to tailor our antibiotics according to the causative organism. In case of culture-negative, broad-spectrum antibiotics should be used as exactly what I've done, and I added vancomycin in addition to the gentamicin included in the cement itself. I always go through the website and the app for the ICM Philly. You could download it on your iPhone or Android. And again, you could have a very nice application that includes to you the very important tools like the diagnosis of PGI. They call it PGI DX. In addition, paper of the week, other documents, PGI risk, etc. In addition to even the ICM slides. Okay. In addition, you can get these nice tables, including this for the available antibiotics and antifungals, which can be used in the cement spacers. I always keep it on my mobile, and I always go for the dose and the activity and the how much is required per pack of cement. So whenever you encounter a multi-resistant organism, what kind of antibiotics? Well, they usually recommend vancomycin. But in vancomycin-resistant strains, we need to include to our judgment the known susceptibility. We need to involve our microbiologist, infectious disease specialist, but also we need to consider the renal function and the antibiogram of the organism in our local facility or our local hospital. So please try to discuss these difficult cases with your microbiologist or infectious disease specialist. They would suggest some very helpful advices. Again, these were the culture. What antifungals, route of administration, duration of treatment should be utilized? Well, they usually recommend fluconazole by both oral and intravenous routes, and also amphotericin B as a secondary consideration, but may be less well tolerated. And definitely, I would apply for this two-stage revision whenever I encounter one of the fungal PGI, with a minimum treatment duration of 6 weeks. Following revision, treatment with oral fluconazole 400 milligrams daily should be continued for 3 to 6 months. So it's long interval. Again, I would always revise the tables I just mentioned. In addition, there is a very nice pocket guide to diagnosis and treatment from Pro Implant Foundation. And they usually have these this nice table, including the last row here, explaining what could you use whenever you encounter the fungal infection or candida species, etc., for the cement space, and how much you need to add per pack of cement. So fungal infections are difficult to treat. We usually use amphotericin B lysosomal and voriconazole as an alternative. So in this case, how could I manage further after knowing that in the first place she had this very bad fungal infection? Well, I had a deep thought with the infectious disease specialist and with the patient family, and because I wasn't quite sure whether this has been treated properly and now we are free of infection or not. So taking into consideration the high risk of persistence of this organism, in addition to the clinical suspicion, etc., I ran this discussion and we agreed that I'm going back again, taking this patient back to theater. This was about 2 to 3 months after the first stage. And this was I think it was 11 weeks after the first stage, after sorting out the logistics of the insurance and the approvals for the surgery. And we decided to take some samples and we decided to go for another first stage as a wise decision. And we thought that if we get back the cultures as being negative, we could proceed to the second stage. But also I applied some antifungal according to the what I just mentioned in the cement spacer, in addition to the antibiotics guided by the culture and sensitivity that was revealed in the first stage. We added amphotericin liposomal in the cement spacer, and then we continued on fluconazole oral, which provides synergistic effect in addition to another aggressive debridement. We took some cultures, 5 to 7 actually, extended. We thankfully these cultures came back as being negative, no growth, bacterial or fungal. And then came to the question, do we need to aspirate or culture before the second stage? Any metrics to determine timing of reimplantation? So according to the consensus, there is a very nice question, important question. Is there a role for obtaining cultures before, at the time, or at the time insertion of the prosthesis? Well, again, this is according to the consensus, the preoperative aspiration of the joint should be determined based on index of suspicion. So you might come across some surgeons who usually have aspirate before every single revision, and some others might just leave it according to the index of suspicion. There is direct correlation between the outcome of the two-stage exchange arthroplasty and the culture results during the reimplantation. What metrics should be considered to determine the timing of reimplantation after two-stage exchange arthroplasty? Well, again, there is no definite matrix. However, timing of reimplantation should consider resolution of the clinical signs of infection, downtrend in the serologic markers, and this is very important. We don't need the ESR and CRP to be back to normal, but we need to watch for the downtrend, declining of the results of the CRP. In addition, if we have synovial analysis, we need to include the results if aspiration is performed. Again, as I just mentioned, is normalization of the serological markers necessary prior to re-implantation? Well, no. Again, according to the consensus, a trend and decline in the CRP and ESR is expected. So surgeons should not wait for complete normalization of inflammatory markers. But again, I will always guide myself by my clinical judgment. What is the diagnostic accuracy of joint aspiration of cement spacer in conjunction with clinical evaluation, imaging, etc.? Well, the diagnostic accuracy isn't known. But again, the decision to perform aspiration on a spacer for a spacer is depending mainly, or should be based on the index of suspicion for persistent infection and individualized, and according to the surgeon discretion. Another question: should patients with periprosthetic joint infection caused by fungus undergo typical 2-week antimicrobial holiday prior to re-implantation? Well, no conclusive evidence, and in this patient, I did not stop the antifungal till I took her back to theater. What intraoperative metrics can be utilized at the time of intended re-implantation to help decision making? Well, you could definitely add intraoperatively frozen section and leukocyte estrays, and that's what I have exactly done on the second stage. And I did not include the frozen section. I only included the leukocyte estrays. But again, I was sort of comfortable because the culture which I got from the first stage was basically negative, in addition to the progress of the patient and downtrending of the ESR and CRP. That's how I treated this patient with one of the titanium revision cups, just to manage the protrusion after removal of the cement spacer and everything. And I treated her with longer stem, the shortest long stem. In addition, the greater trochanter was quite weak, so I applied a couple of backpack circulars in a backpack technique just to protect the greater trochanter and the insertion of the rather flimsy or weak greater trochanter. And that's how it looked. Again, just to remind you about the SMART application, and that you could apply the criteria we just mentioned, the major criteria, minor criteria, apply the score, and then if it's still inconclusive, you could also use intraoperative diagnosis. But again, in my humble experience, it's not a stone score like if it's 6, this means definitely infected. No, I would always insist on my clinical judgment for every single case. You need to proceed with caution whenever you have adverse local tissue reaction, crystalline deposition, arthropathy, inflammatory arthropathy, or slowly growing organism, at which point the proposed criteria might not be that accurate. Just a final brief about the edges, because some junior trainees might ask which one I should use. Again, I'm pretty happy to involve both, because having more than one score, more than one criteria or consensus might actually add to our knowledge and help us manage better BGIs. The EBGIS consensus or EBGIS definition includes what's called the 3-level traffic light definition. It does not distinguish acute from chronic, early or late. Even they did not include the ESR. It didn't apply scores to test criteria because they think that we can't apply like one score for specific test while the other score might get 2 points. They were not quite agreeing with this philosophy. We have to appreciate that it has been applied in fracture-related infection and actually currently is being validated for PGI as well. So it includes 3 groups where infection unlikely, and also infection is likely, and infection is confirmed. And how does it work? It's basically, just to simplify it, it includes clinical, laboratory, and radiology. So they include first clinical, and infection unlikely whenever all findings are negative, let it be clinical, laboratory, or imaging, as we radiology, mainly nuclear imaging. Okay, so if you have A, B, or C all negative, so infection is unlikely. If the infection is likely, if you have two positive findings like A and B, clinical or laboratory, or A and C, clinical and nuclear scan. Infection is confirmed if any is positive among the clinical here of sinus tract communication with the joint, plus minus visualization of prosthesis, or B, which is basically laboratory, because there is no imaging and no need to have, or the nuclear image is not included in the infection is confirmed. So again, I just try to include this consensus or definition just to enrich our discussion today, and just to tell our junior trainees that there isn't one valid or one consensus just we could use to validate our views about the PGI and confirm the diagnosis of PGI. Finally, there may be other situation when a patient is infected and does not meet the diagnostic criteria of either the EBGIS or the consensus and vice versa. At which point, clinical judgment should still prevail and guide the physician in the management of patients, and your index of suspicion is the most important test. And to conclude, diagnosis of PGI is a multifactorial process. Overdependence of a single test should be avoided by all means. Every patient comes to you with a painful total joint arthroplasty, let it be hip or knee, should be considered infected until proven otherwise. And please read the guidelines, involve them, have a good view of the consensus and also EBGIS definitions and other definitions, because there are other definitions like the white, etc. And try to include different tools in your diagnosis. But again, your clinical index of suspicion is the most important, and clinical judgment is the most important. Thank you very much.
Thank you so much, Professor Mahmoud, for this very interesting presentation. Thank you so much, sir. We are ready to receive questions. And my first question, sir, that you said that you made for this patient an aggressive debridement. How aggressive the debridement was?
Well, I'm aggressive. I'm a pelvic surgeon as well. I do acetabular surgery. So I was aggressive both on the femoral as well as the acetabular side by removing every single tissue I would come across and which looked to be suspicious. Obviously, it takes longer time. It takes for me to be very careful, especially on the pelvic side. But again, it went very well at the end. Usually, whenever we say this is very difficult case, it turns out to be not very difficult as we would expect. I was lucky, so I didn't encounter, whenever I was removing the protruded part of the cement, I was preparing myself that it might cause a lot of bleeding, but I was very careful. I didn't need more than the posterior approach. I'm a big fan of it, but I was planning also if I might need intrapelvic approach, I prepared myself for that. But usually, the posterior approach is usually enough to remove the cement protruding into the pelvis.
Yes, sir. Did you need angiography in such a case, sir?
Not really. Previously, when I was, I used to do that routinely because I usually say, well, it might be attached to so and so and so. So I didn't need in this case, just out of my gut feeling, really, and from the other cases which I have previously done. But again, just a word of caution to all our trainees. If you are in doubt, please arrange for angiography and involve or get an advice from one of your vascular surgeon's colleagues to be on standby in case you might encounter any intraoperative bleeding or injury.
Yes, sir. We have one question from Dr. Gamal Qasim. Is that necessary for bicompartmental revision if periprosthetic femoral compartment fracture with no infection in all rheumatoid patient?
Sorry, again, does he mean that we need to remove both sides of the joints? Or, sorry, I didn't get that.
I think so. The question is...
Well, there is definitely some literature about single stage, single component exchange in the setting of infection. But there are some proponents. But again, in my humble experience and my preference, I would like to remove both components. And I wouldn't go for single component exchange. And those proponents might say sometimes it's really very well fixed to the extent that you can't remove them. You might cause more destruction if you remove them. But again, in my humble views, I would always do my best to remove both components as much as I could.
Yes, sir. Dr. Srinivas, you have a question, sir?
Yes, sir. Thank you very much, sir. That was an excellent talk. I would like to ask what parameters or tests would you use for diagnosing or establishing infection in case of immunocompromised patients?
Right. Again, as I just mentioned, I would definitely these are a challenging subset of patients. But again, I was always follow what I've been mentioned, ESR, CRP, in addition to aspiration, and expose the aspirate to different items, which I just mentioned, including definitely the culture, extended culture and sensitivity. And I would insist to get fungal as well as mycobacterium, in addition to atypical things, in addition to white blood cells and synovial PNLs. However, and I always insist on involving my colleague from infectious disease specialist, and we always investigate whether they have like other disease concurrent infections like viral, like HIV, etc., etc. It happens that we treat a lot of addicts. Now it's apparently in vogue that some addicts inject their hips anteriorly into the veins in the anterior aspect of the hip. And I have quite a few, in fact, several patients who have native septic joint, hip joints because of these infections. And some of them are really immunocompromised because they are obviously intravenous drug abusers, at which point I always involve the infectious disease specialist and I always apply what I just mentioned. Currently, we don't have in Egypt and in my facility the molecular diagnostics. Well, they are there, but they are very expensive to include them. So definitely in some countries which might have these facilities, they might be very handy. So I always include ESR, CRP, aspiration, and all these tools I mentioned, in addition to leukocyte esterase, and then sonication, and sometimes in some places, like in my university, frozen section intraoperatively. Yeah.
Mr. Menon, what's your opinion on this? I think you're muted. Sorry.
Unmute yourself. Yeah.
Yes, please.
So are you mentioning about immunocompromised patients?
Yes.
So what we tend to do here in the UK is that obviously you got to be in all these. In fact, all revision cases in the UK are discussed in what is called as an MDT. So we have a meeting which involves, normally there will be almost about 10 to 15 orthopedic consultants from different hospitals in a region. And we've published some data on this recently, which has appeared in Hip International. So there'll be an infectious disease specialist as well, and a microbiologist. And what we tend to do is these kind of complicated cases, we would follow what the team say. They'll specifically tell us to do certain things. We do come across drug addiction as well. There is a native septic arthritis. So what in these kind of patients, what you might find is that I have seen a patient with cirrhosis of the liver, whom I've done a 2-stage revision of the knee. Every time the CRP was normal. I've almost taken the CRP about 15 times during a period of time. And we found that it was normal. So there can be a lot of, these patients will have also polymicrobial organisms quite often. They can have fungal infections. And you therefore need to really clarify with your microbiologist what is the best medium to send it. We always send for histopathology as well, which is a very important aspect of investigation. including and specimens from various sites, minimum of 5. We have a special infection sampling tray as well, which we use different instruments. So for each site that you take a specimen from, you use one set of forceps, one blade, and or a particular, whatever instrument you use, a cocker, and we take one sample, then that is discarded. We use a second sample and you have to also have a certain number of specimens which are positive. It's just getting one. Suppose you send 8 specimens and one has come back as positive, that really isn't diagnostic of infection. You have to have a certain percentage. Normally, at least if you send 8, about 3 or 4 of them, if they grow the same organism, it's easy. But if in these patients, it can be more difficult because you can get different organisms. For example, you can get a polymicrobial with enteric organism, polymicrobial with, say, something like Proteus or a fungal infection, all these things. So those are therefore more challenging to treat. And we always involve medical specialists as well, because sometimes you might have to, particularly when you're doing the second stage, you might need to get these patients, to see if there is a clinical immunologist can look at them and see if there is any way their immunity can be enhanced. Rheumatologists, obviously, to assess if any, the various drugs that they take, when they exactly should be stopped, and when we can recommence those drugs. So these are some of the specific precautions we take with this thing. And coming to one more aspect, which was a question that was asked, this retention of processes. We do retain, I'm sure that you might be doing it there as well, but in patients with early infection. So suppose you come across with somebody who's had a hip replacement and you're able to go in within, say, a window of about between 2 and 6 weeks. If you pick up infection, then you can do what's called as a DARE, debridement, antibiotics, and implant retention. So this is something we try and do in very early revisions. So, early stages following an infection. So if you get in there and aggressively treat them, and this is done quite often, it was in Oxford, for example, they would do this. They would give antibiotics for a period of about between 6 to 9 months. And you get something like, depending on how well you do it, the debridement, etc., you can get at least about 60% response to cure of the infection. So which is not too bad, considering that you're not doing, revising all the components, which is got more morbidity. So early infections, you might get away with a DARE. And now we will get the data on this because we've started a new registry. It's called the BAJIR, which is the Bone and Joint Infection Register in the UK. So obviously, it's just a new registry. So we will start getting results of these kind of procedures maybe in about 5 years' time. So at this stage, it's the early stages. But generally speaking, if you want to get the maximum chances of eradicating infection, then you're better off revising all the components, debriding, doing a radical debridement, and that increases your chances of eradicating the infection.
Yeah, definitely. I totally agree. Definitely. I totally agree. But I think the question wasn't about there. We all well aware about the different treatment options for PGI includes there, which is very valid in some cases, but again, with rather not very guaranteed results, up to 60-65% in some series, in addition to single stage, 2-stage antibiotic suppression, etc., or resection arthroplasty. But I think the question was basically about single component exchange. That's what I thought. Yeah, so but I totally agree. There is one valid option, definitely, whenever we encounter, and this is very important to say, the earliest to interfere as early as possible. So if I would always watch my patients very closely if he's developing hematoma, etc., or she's developing hematoma. So I might come in as early as possible, 7 days, because it used to be said 6 weeks. Nowadays, there is a divide. Some might say, well, it might be successful 3 weeks, 4 weeks, 6 weeks. Again, there isn't a time frame, but the recommendation is to go in ASAP as much as you could and exchange the modular components. Yeah.
So I think that you go in as soon as possible, but after 6 weeks, the results start dropping substantially. So by 6 weeks, you've missed the boat.
Yeah,
so that's what I was trying to say. So obviously, if you don't wait for the full 6 weeks, if I diagnose it today, I will try and go tomorrow. That's what I would try and do. I wouldn't waste time. So I think obviously you will have to medically optimize the patient first, just to make sure that they're fit to undergo surgery. And I think these are all in the early stages. So I think, more data is required. And most of the things in orthopedics, when you actually look at the evidence, you find that the evidence is actually not very good compared to some of the other specialties like medicine and other specialties where they do much more research than us.
Yeah.
May I ask one more question to Professor Abdel Karim? This is regarding bone scan for infection.
Sure.
Can we use it for acute infection? And if not, when is the best time to use it to diagnose infection after a total joint?
Yeah. Absolutely. This is a very nice question. As I mentioned in my talk, I wouldn't use it in acute infection at all. It's very expensive. And again, the high value bone scan, again, it should be combined with something like gallium, sulfur colloid, etc., and also 111 labeled, indium labeled. And these are actually very expensive for a country economically challenged like my country. In addition, we have to be well aware that up to 2 years, as I just mentioned, even up to 5 years, according to the EBGIS, for total hip 2 years, 5 years for the total knee. So definitely I would never resort to that within the first 1 to 2 years after arthroplasty, because it might have false positive results. And again, according to the consensus, I would use it after this interval if still in doubt and I'm not planning or I'm not very sure whether this patient is infected or not. And probably it's role to if it's role in these subset of patients which are not planned to have surgery, and again you're still very unsure whether they have infection or not.
Thank you, sir.
I would agree with that. I think one of the things I would say, a bone scan, a negative bone scan is what is really diagnosed.
Yeah, sure.
If it is positive, then, well, you're not very sure. That's a problem.
Yeah. That again, after the interval, I'm stating that especially for our junior trainees, because sometimes after 1 month, if they want to exclude infection, they send the patient to have bone scan unnecessarily. And again, what we meant to say negative is yes, of good value. However, you have to, after doing the other tools and tests we have mentioned about.
In fact, we normally don't use it very often here. With bone scan is not normally used very often, and I think the reason for that is, and also you've got to realize that a bone scan has got something like the equivalent of 200 X-rays. So it's a lot of radiation exposure for a patient as well. That is something that is often forgotten.
Absolutely, totally agree.
Thank you so much, sir. Finally, I would like to thank our dear speakers, Professor Dipen Menon and Professor Mahmoud Abdel. Many thanks for my dear friend, Dr. Srinivas. We apologize for the webinar in the next week, because from both Egyptian and Indian sides, we have some problems next week. And our final and last webinar will be on the Friday, 10th of November. And then we come to the end of the Egyptian-Indian online course. And we come to another online project with a very good scientific value. Many thanks to all of you, and see you, inshallah, in another very fruitful webinar. Thank you so much, sir. Thank you.
Thank you very much. Thank you. I was delighted. Thank you very much, Professor Kambhampati and Professor Menon. Thank you. Thank you very much, Professor El-ashhab. Thank you.
Thank you, sir.
Bye-bye.